Oh, hello and welcome to Heart Health 101. My name is Dr. Lissa Gall, and I will be your guide this evening about all things about the heart. So, as usual, this presentation is given in the context of whole life medicine, which is the model I'm using at Resonance Wellness when I'm evaluating your healthcare condition. And today we're going to explore the various components of both alleviate and align that can contribute to heart disease. And I think that the concept of heart disease is pretty vague for most people, but be that as it may, we're going to learn to help prevent heart disease with lifestyle measures, which we're going to discuss tonight, as well as improving existing heart disease. And in fact, we have a lot of room for improvement in this typically. So the heart is probably the organ with the most metaphorical language associated with it, and there's good reasons for this, and we're going to explore that today as well. So there are some obviously amazing heart facts. So your amazing heart is about the same size as two fists in an adult and one fist in a child. Your heart beats 100,000 times per day, 35 million times a year, and about 2.5 billion times in the average life. And heart muscles are very strong. They contract with a force about double that of a leg muscle during sprinting. The aorta is about as big of as a garden hose. The capillary beds, though, are one red blood cell thick. So a capillary is so fine, it takes about 10 of them to equal the width of a human hair. You have a lot of blood, 5.6 liters. It's circulating about 3 times through the entire body per minute. That's about 19,000 kilometers of blood flow a day. And your heart pumps about 3 super tankers. That's the big ship that floats with the oil in it, worth of blood per lifetime. So it is an organ that's under an incredible amount of demand. It also is very highly perfused. So there's a lot of blood vessels in the heart and around the heart. And it is predominantly muscle. So it does a lot of work. And it's one of the reasons why when something goes wrong, it doesn't go well. So, like I said, there is some confusion about what heart disease actually is. And so I thought we could take a look at what it's meant when we use the term heart disease. So, heart disease can be roughly divided into 4 main types. There's coronary artery and vascular disease, there's heart rhythm disorders, there's structural heart disease, and then there's actually heart failure. So, coronary artery and vascular disease are due to hardening of the arteries. People have heard that term before, hardening of the arteries. It means there's atherosclerosis. So, coronary artery disease happens when the arteries in your heart are narrowed or blocked. It's the most common kind of heart disease, and it's the cause of most heart attacks as well as angina, which is a kind of chest pain. Vascular disease is also causing problems in other blood vessels, and that can reduce blood flow and affect the function of your heart as well, especially if you are pumping against a vessel that's not flowing particularly well, like in the leg as an example. And heart rhythm disorders they basically cause the heart to beat either too slowly or too quickly or in a disorganized fashion. So there's millions of Canadians that experience heart rhythm disorders, which actually disrupt blood flow. There are many types of heart rhythm issues, otherwise known as arrhythmias. Some have absolutely no symptoms or warning signs of anything, and others can be quite sudden and fatal. Structural heart disease is where there's abnormalities in the actual structure of the heart. So that's including the valves and the walls. So there's an inner wall, which is a kind of tissue that is very, very smooth. It's smoother than glass. The inside of a capillary and the inside of your heart have a kind of endothelium in them that is very smooth. And the reason for that is that because blood is going at such speed through those vessels and through the inner part of your heart, that surface has to be smooth enough to not induce platelet clumping. So, and you can actually have lots of different kinds of structural heart disease. A lot of it is congenital. Some people will not actually figure out they have a congenital heart condition until much later in life, because typically we don't do a lot of screening for that unless people are symptomatic. Or it can be acquired. So you can have a structural heart disease happen if you have an infection, as an example, or it can just happen over time related to other heart disease aspects or circulatory disease aspects. Heart failure is the definition of when the heart is damaged enough or weakened enough that it is not pumping appropriately. It's most often caused by a heart attack. I wrote it down here as a myocardial infarction or an MI, or if you have extended hypertension high enough to actually enlarge the inside of the heart. So there's usually not a great cure for heart failure once you get it to the place where the heart is enlarged. But if you have an early diagnosis, or you know how to make your lifestyle changes, and to a degree in heart failure, medication is pretty much often necessary, can really help people lead an active life and stay at a hospital and just live longer. So other heart diseases as big categories include infections. You can also have enlarged heart muscles, and you can have inherited disorders of all types. You can have, these are the main ones, like I said, but there's quite a few little problems that can happen with the heart over time. And then some of them, people assume that they're problems, but they're really not. Sometimes you can actually have extra sounds, as an example, if you just have a really strong heart. So people get something called a split S2. And if you're an inexperienced physician and you listen to that on it with a stethoscope, it can sound like there's an extra beat. So just keep that in mind. You know, lots of heart diseases, like I said, don't have a lot of symptoms to them. This is why we try and do some sort of screenings, but a lot of heart disease is actually not discovered until it starts to become a little bit more significant, because you can compensate for that so well, given how much activity your heart actually does. So I thought I would take a quick gander through the methods that we have to evaluate your heart and the risk factors that are correlated to heart disease. So there are some common evaluations for cardiovascular function. The first is like just normal in-office physical exams, where we're listening to your heart, listening to the sounds that it's making in the various different locations on your chest. And the reason that I'm putting the stethoscope in different locations in your chest is because each placement actually is listening to a different thing. So we're listening to either a different valve, or we're listening to the apex of the heart, where you hear like the majority of the lub-dub beats. So I'm actually listening to hear if I hear a murmur, or if I hear like a machine sound, or if I can hear that the heart is beating irregularly. Also in office, we're going to do blood pressure exams. And what we're actually listening for there is the top end of what the pressure's like, and then the bottom end. So obviously we're using a blood pressure cuff for that, to listen to that. Normal blood pressure is 120/80 and less. So that's not to say that your blood pressure can't be a little bit elevated depending on what you did. Like if you hiked up my big set of stairs and then we took your blood pressure, most of the time it's going to be, you know, another 10 points higher than that, depending on how long we wait for the heart to calm down. But it's a pretty standard measure, and it can give you some early warning signs, especially if it's consistently high or where we hear a sound consistently. Now, there's also the electrocardiogram. So this is known both as an ECG and an EKG. EKG is actually the German word. So cardio starts with a K in German. People get quite confused whether or not they're having an ECG or an EKG, and is that the same thing? There is also something called an EEG. That's a test of the muscle function itself, and it's a totally different kind of test that requires putting a wire into a muscle. But the basic one that has the electrical leads that are pasted to your chest is an ECG or EKG. And what it's showing is if the electrical activity of the heart is normal. So we're actually passing current from pad to pad from your heart, and we're examining the trace. And so I put a little picture here on the top of the EKG tracing. There's a very specific kind of waveform that you'll see recorded with a sensitive machine that tells you what the electrical activity is across the musculature of the heart. So if there's a problem in the heart, like you've had an MI that you don't know about and you've damaged a muscle, there will be changes on the EKG tracing. Sometimes those changes will only be temporary and a heart will heal. And then other times it will be permanent, depending on what the damage was like. Now, an echocardiogram is an ultrasound of your heart. So you can see that it looks a lot like a pregnancy ultrasound. It's basically a picture of the heart anatomy. And what we're predominantly using echoes for is to see whether or not there's actually a structural problem, especially with valves or with the overall inner shapes and sizes of the spaces in your heart, and also of the large vessels and valves. So it's a different kind of test. It's not complete by itself. Most of the time, if there was a concern where there's symptoms that could potentially be traced to the heart, we would be using both an ECG and an echo to evaluate that. So you can also use a chest x-ray to evaluate the size and the shape of the heart. So just a normal anterior posterior view of the chest will show you whether or not the heart is taking up more space than it should. The average heart will be about 42 to 50% of the thorax width on a chest x-ray. So if it's larger than that, we already know there's heart enlargement or inflammation, or there's a problem potentially with pericarditis. So that's a quick screen, but it doesn't have a lot of detail in it. And that's why it's not the first thing that we would use. If you went into the ER with chest pain, then they would normally be doing all of these tests simultaneously. So the last set of tests here, I mean, you can use a set of lab tests. There's some basic risk factors that can be measured that way. That kind of testing is also not super perfect. And some of you may have already had, as an example, a SpectraCell test, which is a much more complex blood lipid profile that actually gives us more detail about what kinds of blood fats are elevated and whether or not they're a concern or not. You can also use an angiogram. I didn't put this up here, but an angiogram is basically a test where you get a catheter threaded up through your leg vein into the heart, and you're basically putting a contrast dye into the heart and then taking live X-ray images. The reason for that is you're trying to get a sense of whether or not there are blood vessels in the heart that have been impeded by plaque buildup or inflammation. You can also use something called a Doppler. So Dopplers are usually used for carotid arteries to see whether or not there's issues in the blood flow to the brain. This is the major vessel in your neck. Dopplers are also used for vein evaluation in the legs. So if you have varicose veins or the potential for a thrombus, usually we're going to be using that. It's a kind of ultrasound. You can also use Holter monitors. That's a kind of monitor that has a couple of leads on it. You wear it for about 24 hours. It's common to use one of those if people are reporting an arrhythmia, but the doctor doesn't hear it or doesn't show up on an EKG tracing when people are being measured. And that's just to rule out whether or not it happens under certain circumstances. It only happens every once in a while. And as a consequence, you can't catch it when you're in the office. Now, cardiovascular disease is the leading cause of death worldwide at about 17.7 million people per year. You can see how this translates to the Canadian population. Now, this is actually not the biggest cause of death in Canada. Cancer is. It's probably about double the number of people die of cancer than heart disease, but it's still very much up there. It just happens to be a leading cause of death worldwide because there are certain risk factors that aren't as mitigated in other locations as they are in North America. And then there's other risk factors that we have in North America that are substantively higher than some of the international community. So you can see that about 1 in 12 adults in Canada over the age of 20 have some sort of diagnosed heart disease. So these are just the people that we know about. And the death rate is, relatively higher in people who have an established heart disease than people who do not. Men are more likely to suffer a heart attack, but that doesn't mean that women don't have heart attacks. They just have them in different ways and usually a little bit later in life. So we're going to come back to that in a few minutes. So like I said, worldwide, cardiovascular disease is a big issue. Even worldwide, it's caused really by modifiable risk factors about 70% of the time. So you can see that those risk factors are metabolic, behavioral, environmental, psychosocial, and socioeconomic. And as an independent measure, how strong somebody actually is physically. That's what's meant by strength. We're going to see that in a sec. And then there's kind of like a multitude of other causes that can contribute. But like I said, cancer causes twice as many deaths as cardiovascular disease in high income countries. And cancer is actually the lowest in low income countries. So there's just some really interesting questions to be answered about some of these risk profiles. So I thought you could, I'm hoping you can kind of see this large enough on your screen. But the causes of cardiovascular disease are not the same around the world, like I was saying. So here, the purple bars, there's pink, blue, and then purple bars. The purple bars are high income countries like Canada and the United States. And you can see that on one side of this chart, the left-hand side, we're really showing the risk factors that are the currently diagnosed cardiovascular disease cases. So you can see that metabolic risk factors, which are the hypertension, the diabetes, the cholesterol ratios, and the waist to hip ratios are pretty high in our group. Our purple bars are the biggest. You can also see the behavioral risk factors of tobacco use, alcohol use, a poor diet, and low physical activity as being important, particularly the use of tobacco. I'm not 100% sure, though, how they measured that poor diet doesn't cause cardiovascular disease. I think, the data might be a little iffy there. But I guess they think that in poorer countries, the diet is worse and it's directly causing it. I can tell you there are a lot of people who are causing heart disease with not so great diets in Canada too. You'll also see that unlike low-income countries, depression is considered to cause cardiovascular disease in higher income countries. We're the only bar in there. There's also the risk of having low education correlated probably with behaviors, but also with socioeconomic circumstances. And like I said, right at the bottom here, we're seeing low grip strength. It's enough of a factor that we actually measure it and report it separately. So as you can see, there's a lot of choices under our control. That's kind of the hope I'm wanting you to see in that slide. So there's a quote from Mark Hyman, MD. He's a fairly well-known functional medicine doctor, but he actually directly was quoted as saying to think that we can treat heart disease by lowering cholesterol, lowering blood pressure, and lowering blood sugar with medication alone is like mopping up the floor while we leave the faucet running as the sink overflows. And I thought that was a pretty clever analogy. It just highlights the need to discover outlying causes that put you at risk for heart disease rather than just treating the symptoms with medication. And obviously you can reduce your risk if you just quit or you never start smoking, if you exercise regularly, if you maintain a healthy weight, and if you really eat a diet that suits you. So, I mean, you can eat fruits and vegetables with each meal. You can limit um, saturated fats or create a good balance of fats and decrease added sugars. And if you choose to eat, things that are not great for you, doing so in moderation or doing it in combination with other things that mitigate their effects. So let's just take a moment to dive in and discuss diet. I know you guys know of me as basically a pretty broken record, but diet is a high priority to improve risk and management of cardiovascular disease. We already know that the healthiest diet looks like this. So 50% non-starchy vegetables, 25% high quality protein and fat, 12% fruit, 12% starch in vegetables and whole grains together, not separately, 1% ferment, and 1% salt and seaweed. And of course, variety is key. We want to have as many things rotating through these categories as we can. So this is the diet with the most epidemiological evidence. That means that if you take big pools of tens of thousands of people and they eat this way versus another way, you can tell that these people who eat this way are the healthiest. Hands down, no negotiation. So just working on getting these proportions will serve most people. Of course, we can be very, very particular about what you might put in these categories, and we might even tweak them a little bit depending on who you are. So we can ballpark that further, and we'll probably also be able to use some genetic testing to personalize it in the near future, a little bit further than we do now. So diet aspects to consider, there's obvious culprits that have an impact on the metabolic aspect of cardiovascular disease. So in essence, we're looking to reduce or eliminate foods that just don't exist in nature. So if you couldn't walk up to a tree or walk up to a plant and get it that way, this is a good measure of whether or not the thing exists in nature. Basically things that are not processed wherever it's possible. You want to not eat damaged fats. In North America, we do some pretty wild things to foods, like we deep fry a lot of things. So fast food and fries, this is one of the reasons why they have such a high correlation to poor health outcomes. Damaged fats are basically like things that are already oxidized. And so your body actually has to do all of the work of correcting the fact that it's damaged to see if it can actually use it as a fuel or at least eliminate it. Things that, basing a diet on starch is a bad idea. So, things like sugary cereals, cookies and pastries all the time, diet sodas, processed things, like margarine, too much deli meat, things in packages full of starch. We can also improve our risks by not eating like we're hard laborers, eat when you're hungry, not because the clock told you to. We can also consider some other dietary behavior aspects. I mean, human studies do show promise for cardiovascular benefit in intermittent fasting. The exact mechanisms of that are not totally understood, but it appears to positively impact multiple cardiovascular risk factors, including obesity, hypertension, dyslipidemia, and diabetes. It also is associated with improved outcomes after a cardiac event. So that means you've already had a heart attack or you've already had stroke. These, hopefully, you could consider that. Intermittent fasting is basically where you restrict the number of hours in the 24-hour cycle that you eat, it could look like skipping a meal. Again, it depends on the person's tolerance for this, and sometimes it takes some time to work into it. If you there's a couple of things that actually create some really significant problems in cardiovascular disease. There was one study that I thought was quite remarkable. This was done in 2014, It was in the Journal of the American Heart Association, and they found that certain dietary patterns actually increase cardiovascular risk. And they used about 21,000 records from patients to basically look at who died or not. And they found that if you eat starchy snacks high in white potato or starch after any meal, you could raise the risk of dying from any illness by at least 50% and the risk of dying from a heart-related problem by 57%. It was also that people who were eating lunches high in refined grains or solid fats like cheese, cured meats, and a bunch of added sugar, that's really very common in our culture, that kind of lunch. They had a 44% increased risk of dying from heart-related issues. So just by changing your lunch and not eating potatoes after things seemed to help. And people who ate the most servings of things in their whole state, so a whole grain, fruits, even whole dairy, nuts, orange vegetables, red vegetables, and legumes gave a 23% lower risk of dying from heart disease and a 31% overall less death risk. So it's pretty remarkable what impact the diet can actually have. And those are just very basic things that you can do. So no potato chips with lunch. That's a bad idea. So exercise obviously should always be a part of a healthy lifestyle. But if you're wanting to target a healthy heart, there are some very specific exercises that are recommended. First and foremost is strength and resistance training. And like I was saying before, strength is actually an independent risk factor for cardiovascular disease. The American Heart Association recommends things like jumping jacks about twice weekly at a minimum, push-ups, squats, things that are actually building muscle volume. It does not matter how old you are, you will always have the capacity to build muscle. A 90-year-old actually has a pretty good capacity to build muscle. It just has to be done. This is an argument that I often have with some elderly patients who think that at 90, that's not possible. And the weakness that they feel is inevitable and from age. And then we have to explain that no, that actually can be reversed. So if you increase your body's muscle mass, you're also increasing the amount of calories your body is burning. That does also help to maintain a healthy heart. Walking is actually a very good low impact recommended exercise. You're just basically going to build up to, as vigorous of a walk as you can. You can go all the way up to jogging and running. But walking, briskly for an hour is perfect. You just really want enough activity to make a difference. You don't want so much activity that you create more problems. And in one paper, as an example, so if you look at like small bouts of daily exercise, peaking where about 50 or 60 minutes of exercise each day, you'll get the maximum effect. But if you go over that, you'll actually sometimes create bigger problems. So studies in endurance runners, as an example, there's one study that showed that the frequency of adverse cardiovascular events in marathoners is equivalent to that in a population with established coronary heart disease. So too much exercise is likely going to be detrimental. So the upper limit for cardiovascular benefit is supported by some data that shows that if an individual completed at least 25 marathons over a period of 25 years, they had much higher than expected levels of coronary artery calcification and calcified coronary plaque volume when they compared them to sedentary individuals. And if you increase your physical activity to more than 3 times the recommended level, you have a higher odds of developing coronary artery disease, especially in white males. So, the plaque quality may still be better than a sedentary person, but I think it's something to really consider. I think when people over-exercise, they increase their inflammatory profiles, and you have to be careful with that. You can do damage that you are not repairing. And of course, if you talk to any marathon runner, most of them will tell you that the marathon is the thing that's going to make them live longer. But there is definitely data that disagrees with that. So it's finding the right balance of exercise for you and how well you recuperate and how well you eat and do the other lifestyle factors for sure. Now, yoga is a great exercise. This actually has a very good impact on cardiovascular disease. There have been 44 randomized controlled trials in some review studies that have basically showed that your systolic blood pressure, which is the number on the top, the 120, the diastolic blood pressure, which is the number on the bottom, which is the 80, heart rate, respiratory rate, waist circumference, waist to hip ratio, total cholesterol, and the independent aspects of cholesterol like HDL and VLDL, triglycerides, your blood sugar as measured by hemoglobin A1C, insulin resistance, all of those factors are improved by yoga. And the rate is pretty good. So, just by doing yoga, a couple times a week, it's very good for you to stretch and get all those muscles out of too tonic of a state, as we often do when we're sitting, or if we do too much aerobic exercise. So very good evidence really for improving cardiovascular disease with yoga, even though it's much more relaxing than the average marathon. So I also wanted to look at a couple of very common myths about cardiovascular disease. So there are things like heart disease is something only older people should worry about, or your tendency towards a cardiovascular disease actually can start much earlier in life, especially now with the tendency of diets and exercise to be so poor. We've already talked about the myth of the extremely active person being healthier than everybody else. And so again, I mean, hopefully not everybody here is running marathons without appropriate recuperation, but if you are, it's something to consider. Some people think that they don't have cardiovascular disease because they don't have any warning signs. Hypertension in particular is often silent. Most of the time you don't know that you are developing it. And you may not have ever even experienced symptoms. Now, granted, if you're experiencing symptoms, we have a different problem. So you don't want to wait for your body to alert you that there's a problem. But the way to know if you have high blood pressure is just basically do a simple blood pressure test. So ask for that if you've never done that in the office next time you're in. You also won't necessarily know that you're having a heart attack based on chest pain. It's common to have chest pain or a kind of discomfort in the chest, but the signs can also be subtle. So there can be shortness of breath, there can be nausea, you could feel lightheaded, you could have pain and discomfort in one or both arms or the jaw or the neck or the back. But sometimes it's minor and it kind of comes and then a couple hours later it goes. Now, granted, that's probably not a major heart attack, but you can sometimes find evidence of old heart attacks on scans that the person didn't know about. People who are diabetic thinking their diabetic medication is going to decrease their risk. If I've ever shown you the Australian risk charts, you will have noted that the diabetic side has a much higher risk for all-cause cardiovascular disease. And that's because you're basically doing damage to tissue by not fueling it properly and then damaging it by having too high of a blood sugar, and blood sugar itself actually damages tissues. So it's not enough to just take blood pressure or diabetes medication to reduce risk. And it doesn't take you out of the realm of the increased risk. Pains in your legs are not signs of aging. Sometimes it can have to do with your heart. So you can have peripheral artery disease that you don't know about and chalk it up to something else. Avoiding exercise after a heart attack. Some people are very afraid to actually walk or exercise after a heart attack because they're afraid they're going to cause another one. But generally speaking, if you, as soon as possible, get moving, a heart attack survivor will live longer if they exercise than if they don't. Taking drugs or supplements for cardiovascular disease, like I will just take this pile of supplements and this will eradicate everything, like an aspirin, or, you can reduce your risks, certainly, but you can't eliminate it. And the effects are only additive to a certain level. You should always evaluate all of your supplements and medications together if you can. Like I was saying before, men are not the only ones that have heart attacks. A lot of cardiac research has been on men, but there's physical and social differences between men and women that have an impact. In particular, things like long-term exposure to estrogen therapies like oral contraceptive pills or postmenopausal hormone therapy does increase your risk, especially if you smoke. And this is true even if you are under the age of 35. I've had patients who had strokes from oral contraceptives under the age of 35. This is also the reason why the time limit on hormone-oriented birth control is supposed to be 10 years or less. And ideally, it's oriented earlier in life. If you're a long-term smoker, some people think they can't reverse that kind of damage, but actually quitting smoking has immediate benefits. So it doesn't matter how old you are or how long you've been smoking, the benefits will start the instant you quit. And after just a year of not smoking, your risk of heart attack actually reduces by about 50%. So after 10 years of not smoking, the risk will drop to that of a person who really never smoked. Heart disease runs in my family, so I can't do anything about it. That is a classic sort of excuse, but heart disease running in your family, like we showed before, there's some kinds that are not genetic. But the thing that is most likely to be genetic is how well does your diet match you? And so that's the piece that's really inherited. It's the epigenetic factor. It's the thing that you're actually doing that is having an impact on the expression of genes. And I thought we could take a look at a slide about that. So 80% of heart disease cases are lifestyle choice based. And so this is really great illustration from a paper in the Journal of the American College for Cardiology. And what this is showing is epigenetics and coronary atherosclerosis. So epigenetics means factors that are having an impact on gene expression. So you inherit the gene, but the gene isn't always on, or the gene isn't always off. You know, some genes you want off, some genes you want on. And they have an interaction with other parts of your physiology. So here you can see with the blue arrow on the left that these are transgenerational epigenetic inheritance issues. So where your ancestors have been exposed to environmental stressors, things like cooking fires, even several generations ago, smoking, dietary influences, chemical contaminants. You know, maybe some of your ancestors have worked in plants or worked in around things that were very toxic before we knew they were toxic. I have a patient as an example who remembers being carried on the back of her mother while her mother had a job spraying pesticide in the orchards in BC. So you can just imagine how much pesticide she inhaled. So these all have impacts transgenerationally. That means if you change the genetic expression epigenetically, that part can actually be inherited. And it can also be reversed, but you can actually inherit it as well. And people don't realize that the behaviors of their ancestors can have an impact on their genetic expression, not just the existence of a gene. It's not as black and white as that. Then you can also see on the red arrow on the bottom, lifetime exposures to environmental stimuli. So these are the same sorts of things, but over the course of your own lifetime. So both of these things are actually contributing. It isn't just the one, and it isn't as, like I said, cut and dry as you have a gene for this thing or not. That is actually quite rare. In the next year or so, you're going to see me introducing some more genetic testing. I finally found a company that I think is making a good job at creating the kind of reports I would prefer people be able to work from. And that's actually one of the first things that they said was too many people get genetic profiles that are very deterministic and make people think like, oh my gosh, you know, I have this risk of this particular disease and I'm never going to get out from underneath it. That's absolutely not true. There's so many actionable steps you can take. And in fact, you can be very particular about your actionable steps if you know the particular genes that you're having trouble with or that you've inherited. So I just wanted to take a look at some of the heart metaphors. I mean, I could think of lots: heart of stone, heart of a lion, heart of gold, heart and soul, letting your heart rule your head, pouring out your heart, wearing your heart on your sleeve, setting your heart on something, breaking your heart, winning somebody's heart, having a big heart, being a brave heart. You gave me a heart attack. Let's get down to the heart of the matter. We have a lot of languaging around the cardiovascular system. We're quite aware of some of the things that have an impact on heart function. And they really do have an impact on heart function. In fact, there's this beautiful TED Talk, and I'm going to show you a couple of images from this. This was it's a highly watched TED Talk by a Dr. Prasad. And so if you haven't seen this TED Talk already, you should go and take a look at it. And in this TED Talk, he was talking about the striking example of what's called Takotsubo cardiomyopathy. So there have been years of gender-based research that shows that there's a temporary heart condition that is this kind of cardiomyopathy. It's also known as broken heart syndrome. And it was first described in 1990 in Japan. That's why it has a Japanese name. And more than 90% of the reported cases are women ages 58 to 75. Research is actually suggesting that up to 5% of women suspected of having a heart attack are actually having this disorder. Most women seem to recuperate with no long-term heart damage, but it often occurs very classically looking like a heart attack. So chest pain, shortness of breath, abnormalities on the ECG that mimic that of a heart attack, but there's no evidence of coronary artery obstruction. And there's movement abnormalities in the left ventricle or ballooning of the left ventricle. And so this is what I'm showing you here on the right-hand side. So Takotsubo means actually, it refers to the kind of jar that the Japanese used to capture octopuses in. So it's called a takotsubo. And so what the Japanese physicians found was they saw that there was a kind of jar-like shape that was occurring in the physiology of the heart. And so here we're actually seeing weakening, various types of weakening of the left ventricle, which is the heart's main volume chamber, as a result of somebody's severe emotional or physical stress. So sudden illness, loss of a loved one, serious accident, natural disasters sometimes are followed by this. There's a lot of different stressors that have been related. And of course, if these sort of things are happening, what's really interesting is that most of you might know that over the last year, I've been doing a bunch of studying in trauma therapy. And what's interesting is in this trauma course, there's a very real recognition that a lot of trauma is placed quite firmly in the heart and is also remedied by using things that improve the function of the heart. So if that has ever happened to you, make sure to ask me about it. We're actually going to talk about that in further detail in a minute. So even a sudden surprise apparently can cause this kind of heart ventricle shape issues, and as a consequence, literally put somebody into semi-heart failure for at least a window of time. Now, many of you may have had me walk you through a heart math exercise. So heart math is designed to develop coherent heart activity. And here's a study as an example. So there was a meta-analysis that showed that compared with patients with cardiovascular disease, those with a high HRV and those with a low HRV had very different risks of all-cause death and cardiovascular events. So if you have a low HRV, you had a 121% and 46% increased risk of dying of anything or dying of cardiovascular disease. And let me tell you what I mean by coherent. So this is an illustration from Heart Math that you might have seen me use before. And what this is showing is the heart rate mapped from 60 to 90 over time. So it turns out that your heart is not beating consistently at 60 beats per minute. It actually varies. It speeds up and it slows down over seconds of time. And the healthiest and most coherent heart rate variability is shown on the bottom panel under appreciation. And that's because often when people go into a state of appreciation in their heart, they actually create a beautiful sine wave based um, improved heart coherence. That's what's known as a high heart rate variability with coherence. On the top, you can see somebody's print that was frustrated. It looks a little bit more like an earthquake. It's not rhythmic and beautiful. It kind of goes up and it's kind of a bit jagged. So when people are stressed out, or in this case, that's labeled frustrated, this is what your heart is doing. Ideally, though, you want to create as much of the appreciation look to your heart rate as you possibly can, and it's trainable. So the heart math exercises literally can improve your capacity to quickly drop into a coherent heart rate variability and improve your cardiovascular risk fairly dramatically. So it's a useful predictor actually of cardiovascular events and death. And it's also a good indicator for monitoring, treatment effects. It's a good monitor to see whether or not you are putting more stress in your body there. So in other studies, we've seen HRV alone or in combination with other risk factors predict malignant arrhythmias and sudden death. Even high intensity interval exercise can significantly reduce this kind of premature death from cardiovascular disease. So you're actually strengthening your heart so you can actually get a better variability. And then, like I said, it's learning how to be focused on positive feelings and appropriate breathing that actually create this beautiful appreciation, coherent sine wave, and a huge reduction in risk. In fact, you can actually reduce your risk of all diseases, all cause morbidity and mortality, and your heart rate variability coherence is a better predictor of how you're going to do as a diabetic than your blood sugar level is. That's how marked it is. Now, there are studies that have shown that meditation has a very good effect on heart cardiovascular disease and heart health. So there was actually a study that was published just last year in June in the American Journal of Cardiology. It examined data for about 60,000 adults over about 5 years. Out of those 61,000 people, about 6,000, so about a tenth of them, actually practiced meditation. And so they asked about a lot of different health topics, but compared with people who didn't meditate, those who did had a lot of heart health benefits. So 35% lower risk of cholesterol, 14% lower risk of high blood pressure, 30% lower risk of type 2 diabetes, 24% lower risk of stroke, 49% lower risk of coronary artery disease. And so meditation could really be a brilliant medicine for your heart. So there's limitations on these kind of studies, obviously, because people are self-reporting. They didn't say what kind of meditation people did. Different forms could potentially have different benefits. They didn't also collect the data on how long those people had been meditating, so we don't know that kind of data in big volume. But I think the evidence was pretty strong, even considering what data that they came up with. So, one important thing to notice is, you're capable of improving your health. Actions that you can take will improve your cardiovascular health and your all-cause morbidity and mortality in this case. So, if you just take a moment to kind of reflect, what things could you potentially commit to improving your cardiovascular disease risks over time? Especially if there's a couple of risks that you're already showing, like that you're a smoker, or that your blood labs, your blood fats are a little bit off, or you're under a lot of stress, or you have the suspicion that you have these gene profiles that are found in your family. So there's lots of different things that you can do there. Now, I know there's not very many people on this particular webinar, but I wanted to share with you that, I'm really planning to do a spring gathering in person this spring, since we've kind of had some little bending here of the rules in recent weeks. So I'm really envisioning doing an online gathering, and I'm hoping that people will like to come and participate in it, depending on where in your journey you are and what you're interested in. I'm kind of hoping to do 4 of these in a year. And I've got a whole bunch of ideas about what kind of topics we might do. But I think the first one we are going to do is probably going to be about trauma and about just kind of processing for ourselves what's happened in the last couple of years as a group. I certainly have had a number of people who are sitting in my office thinking that they're the only crazy person that is just not really sure where this is all heading. And I'm also envisaging that, connecting you to each other, because I think there's so many people that if they were just in the same room, they'd be right on the same page. So obviously we have tons of workshops online, and we have all those recordings now, and I'll continue to do maybe not as many of those because it takes time, obviously, to do these, and it takes time to put together workshops. But I'm hoping, that we'll start a little bit with the heart and then move to mind and body and parts of consciousness that need to be recognized and acknowledged as being traumatized in this last couple of years. So the goals are really to connect and to learn and pick up new skills. I'm hoping to actually teach people heart math in this workshop in more detail, with more different versions of how you can use it. I would really love to create a structure for everybody to keep everyone connected and to hopefully serve as a bit of a booster step into your next stage of healing. So if you're interested and there's a day or a time of day that's preferred, let me know. I'm thinking about a weekend morning for about 3 hours. And I'm hoping we'll get together in the next couple of months. So stay tuned. But if you're interested in that, let me know, because it's useful to have a set of numbers, because I think I could probably only do about 40 at a time. Now, these are our Alleviate webinars that are still going to be done. So March, we're going to do overeating. April, we're going to do produce storage. And May, we're going to do managing asthma if you're an asthma sufferer. And don't forget to go to sign up. And of course, I'm doing okay. I've actually put a bunch of the webinars up now that I was missing from the last couple of months. So thanks so much for attending. It means a lot to me to share this information, and I'm hoping that you all will spend some time thinking about your heart. Thanks for watching. I love to connect to my patient community to inform and inspire, and I hope you'll join us again in the near future. Don't forget to check out whole-life-medicine.com for more webinars and events.